Okay, so good morning, and thank you so much for joining us today. My name is Audrey Paddocks, and I'm the research manager at the McMaster Institute for Research on Aging. If you have not already switched your view in Zoom to speaker view, we encourage you to do so. On your Zoom screen in the top right-hand corner, you should see an icon. The wording under the icon says gallery view. Click on the icon once, and this should change it to speaker view. If for some reason you were not muted upon entry, we ask that you mute yourself to eliminate any background noise or feedback during the presentation. If a question or comment occurs to you during the presentation today, we ask that you please type the question or comment in the chat box, and we'll review these during the question and answer period at the end of the seminar. Please note that this meeting is being recorded. So we'll begin by giving honor and thanks to the Haudenosaunee and Anishinaabe nations as the traditional inhabitants of the lands where McMaster stands. To say that is to acknowledge a debt to those who were here before us, and to recognize our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have to this land, and to reflect on how each of us can do more to learn about the rich history of the land so that we can better understand our roles as residents, neighbors, partners, and caretakers. Today's seminar, Aging, Health Equity, and the Digital Divide, is part of the MIRA One Topic, Two Disciplines series, which brings together experts from two very different fields to discuss important complex topics in aging research. This series is aligned with MIRA's goal of supporting interdisciplinary collaborations among researchers across McMaster. Today, Milena Head and Petch will bring their expertise to address questions around how digital technologies are transforming the ways we work, interact, and manage our health and well-being, and the ethical and practical challenges associated with aging, data collection, analytics, and decision-making. Dr. Milena Head is a professor of information systems and the Wayne C. Fox Chair in Business Innovation, the director of the McMaster Digital Transformation Research Center, and academic director of the EMBA program at the DeGroote School of Business here at McMaster. Her research interests relate to human-computer interaction and technology use and misuse, with a focus on understanding individual differences by age, gender, and culture. She has published over 130 papers in academic journals, books, and conferences, and has been the recipient of several research and teaching awards. Dr. Petch is the Director of Digital Health Innovation at Hamilton Health Sciences and an assistant professor at the Institute for Health Policy, Management, and Evaluation at the University of Toronto from the Division of Cardiology at McMaster University. He's the founder of CREATE, the Center for Data Science and Digital Health, a multidisciplinary research and innovation team with expertise in health system operations, data engineering, data science, software engineering, and interoperability. Prior to joining Hamilton Health Sciences, he led St. Michael's Hospital transformation into a data-driven organization through the deployment of advanced data and analytics infrastructure and co-founding the Li Ka-shing Center for Healthcare Analytics Research and Training, which is home to a team of data scientists with specialization in machine learning, simulation modeling, and natural language processing. Dr. Petch was a core member of CADTH's Health Technology Expert Review Panel from 2015 to 21, is the co-lead of the Digital Health Secretariat of the Hamilton, Ontario Health Team. So I would now like to hand over the reins to Dr. Head, who will speak first, and we'll take all questions at the end of the second presentation. Milena, you're still muted.
Yep, just getting organized here. Thank
Okay,
you so much. Okay, we're good. We're good. And I was waiting for the dogs to stop barking. I do apologize in advance if you do hear barking. There's a couple of dogs behind me that seem to be very, very feisty this morning. So apologies in advance. Thank you so much, Audrey, for that kind introduction. I'm hoping everybody can see my screen. Thumbs up. Yes, excellent. Thank you. So thank you, Audrey, and thank you everyone for being here this morning. Very excited to talk about this topic. It's something that is very near and dear to my heart. I will start us off. I'll talk about what is the digital divide, different kinds of conceptualizations around the digital divide, what causes it, how we can look to help to overcome it. And I'm going to be focusing in on this one topic, two disciplines talk, my discipline being business. I'm going to take a business lens to this and understand how, from a business perspective, we really do a lot of disservice and in many ways further exacerbate the divide in the way we actually design our websites, and also the embedded biases that we have within the algorithms and the AI that we design as well. So let's get started with talking about understanding the digital divide. So when we typically talk about the divide, it can be any kind of technology, but we're going to be talking about specifically here looking at access to the internet. So it's really just the difference of who has access to the internet and who doesn't. And often when we think about this, we tend to classify that kind of divide being by geographic or socioeconomic factors. So geographically, from a country perspective, how developed is the country? In highly developed countries, we have roughly 87% of the population in those countries will have access to the internet. In those that are least developed, it's often less than 20% of the population that might have access to the internet. We also might think about the division between urban and rural, where you might not necessarily have the infrastructure in place to be able to access the internet in rural communities. And then, of course, when it comes to the socioeconomic pieces, the cost itself. Is the cost prohibitive such that individuals might not be able to afford that kind of access? So this is a typical kind of classification that we often see, but a really important one that is one that which I typically really resonate with, because it's one that we have a lot of potential to be able to really overcome effectively, but we often ignore. And that's more so from the attitudinal side and also the digital skills development piece. First off, looking at the fear. People who will purposely exasperate or create that divide because their fear of making mistakes with the technology, not understanding the new technology, and just their general attitude around using the technology, lack of interest in using it, not really seeing the point in using it. You know, I've been living my life pretty well without having access to the internet, or in some cases even feeling, I'm too old, this is not something that would make sense for me. So those are attitudes that create unnecessarily that divide outside of the geographic and the socioeconomic. Digital skills, this is another big one as well. So where we don't necessarily have the skill sets, we don't necessarily have the tools, we don't have the understanding and the experiences to be able to leverage those technologies and everything that comes with it. If we take a look at some stats, for example, in Canada, when it comes to older adults, these are pre-COVID stats, just before pre-COVID. Home internet services, if you are under the age of 50, chances are your household, 97%, is going to have access to the internet. If you are of the age 50 to 64, 92% of Canadians would have access to the internet in their homes. Over 65, it drops down to 74%. If you talk about smartphones, so who does not have a smartphone? Well, if you're under the age of 60, only 5% of Canadians do not own a smartphone, whereas if you get over the age of 50, that number jumps up to 20%. So you can see some big differences here when it comes to age. The COVID effect. We hear often that older adults are really the most vulnerable, especially when it comes to COVID, and could not agree with that more. For lack of a better expression, it's really the double whammy here from the COVID effect. First of all, when we went into isolation, when we went into lockdown, all of a sudden, older adults who so heavily relied on that social support were alone, were isolated. So we have seen this dramatic increase when it comes to increased loneliness, isolation, and affective disorders because of the lockdowns and because of the isolation that was required because of COVID. Now, on the flip side of this double whammy side of this, is that yes, it did encourage, because it necessitated in many ways older adults to actually have to go online to access critical services, but they weren't properly equipped. We have seen over the last 18 months a dramatic, sharp increase when it comes to the number of cybercrime that has surged worldwide because of the pandemic. And in particular, the population that is targeted is older adults. They might have more difficulty in detecting cyber attacks more effectively, and cyber criminals are purposely targeting this vulnerable population in their attacks. So how do we help to bridge some of the divide? So that first categorization, when we talk about geographic and socioeconomic, a lot of it comes down to public funding. So looking at funding of infrastructure to develop those rural areas, to get the infrastructure in place, to gain access. Other approaches look at how do we leverage local libraries and community centers to be able to provide the education and access to these services through the internet. And then having very targeted subsidies, whether it's for the technology, the access, and the education piece. When it comes to the other barrier, the other dimension of barriers, the fear, the attitude, the digital skills, we think about two different kinds of supports. The first one being the cognitive support. So this is really providing the right kind of information packaged the most appropriate way to share the information, the knowledge, the advice of how to best use this technology, developing those skill sets so that individuals are able to better on their own judge, analyze, and understand how to select information so that they're not victimized. And then the flip side of that is looking at the emotional support, focusing more so on helping to relieve some of that anxiety, that stress, building the patience, the praise, the encouragement, the comfort level with the technology. And research has shown that it is this emotional support that is even more important than the cognitive support to encourage long-term continued use of these technologies and of internet. Now, from a business perspective, because I am a professor within the Faculty of Business, the opportunity is absolutely great. These are some US stats. People over the age of 57 account for more than double the generational wealth of those aged 25 to 60. So this is not a niche market. These are, from a business perspective, these are great customers because they have more discretionary income by and large, and they tend to have more free time. But this particular population of older adults, we do them a great disservice. And I'm going to be talking about it from two perspectives. First of all, how we design the interfaces that we design that just further exacerbate that divide, that digital divide, and also looking at the embedded biases that we have within the algorithms and the AI that we have. So I'll focus first on the interface design because this is something that is directly within my own field of expertise and my own passion. How we design to effectively exacerbate, again, that digital divide. The understanding that one size does not fit all. We are all individuals. We all have different kinds of experiences, capabilities, and what works for one individual or one set of people might not work for others. So yes, there are differences when it comes to motivations, why we're using the technologies in the first place, the expectations that we have of using that technology, our experiences that then inform that experience with using the technology itself, our comfort level, and also our capabilities, just to name a few. Unfortunately, a lot of the things that we design, whether it is from a technology standpoint, an interface standpoint, a web page, whatever it might be, tends to assume that everybody will digest and will interpret the information the same way, which is just simply not true. If we just look at a capabilities perspective, as we old, a very simplified visualization of this, yes, there is absolutely this natural decline that happens as we as we age. From one perspective, from a perception perspective, our vision, our hearing, our tactile senses will decline. From a cognitive perspective, short-term memory in particular is impacted. So if you have a complex navigation structure within a website, that can be very confusing and distracting and frustrating for an older adult that has short-term memory issues. And then from an action perspective, it's more so the movement control, the tactile, being able to target on certain small spaces within an interface. So what are some principles that we just naturally get wrong in helping to support older adults, to encourage them to use the technology? From a very, very basic standpoint, the size, the color, the contrast of what we use. We have fonts that are too small. We have click targets that are too small. So here we see different click targets for various social media applications. Very small. If you have any kind of shakiness in your hand, that's going to be very difficult to click on correctly and appropriately, or even to be able to see. Colors that are used inappropriately. So as we age, then we do tend to have color vision, tends to fade as we age as well. So if you're using color to signify content, to signify action, to signify information, if that color is not being interpreted correctly, then you are causing a lot of unnecessary confusion and frustration with your audience. Not enough contrast between website elements. So here we have light gray text on a white background. It can be very difficult to see. And then, oh yes, overwhelmed with dense text, especially when text is stuffed into small spaces without enough white space to separate sections. All of this, for those that might be of a younger generation set, might be perhaps a little bit annoying. Or sometimes we don't even think about it, but when you are thinking about those that might have different kinds of cognitive impairments, this can be very frustrating and can be enough to even further widen that divide and to turn them off from trying to use it. And it's not just the small players, it's all players. Here's an example, which I just grabbed from the bottom of the Apple site. This is their menu, and it is clean aesthetically, but how easy is this really to see? Small font, gray font on a gray background. The font is also very narrow and the targets are small. So how frustrating is this for an older adult? Yes, I did have to delve a little bit into our own website at the DeGroote School of Business. This is at the bottom of our homepage, and most of our pages, it is our menu structure. So it looks pretty clean and pretty reasonable. When you actually try to move your mouse to hover over any of these elements to click on, right now the mouse is hovering over contact. Contact becomes burgundy. Burgundy is a lovely color. Yes, it is the color of McMaster, but a burgundy font on a dark gray background, difficult to see for most of us, in particular if you have any kind of visual impairment. All right, so where we absolutely do not design to accommodate, and we're actually designing to frustrate. Other principles that we tend to get wrong when it comes to navigation. Navigation, especially when it comes to any kind of short-term memory impairment, can be something that makes or breaks the experience and will often turn people totally off of not just that website, but potentially being able to use the internet and being able to navigate in a confident way. Often we have aesthetic that will override intuitive navigation. Sometimes it's just overwhelming information, so you don't know where to go. And inconsistent navigation cues that might change their location on the page or change their formatting or their look or their style from different pages within the website itself. Navigation should fundamentally tell us, where am I, where have I been, and where can I go? And it should do that in a clear and effective manner that resonates with all the population, all the users that could be potentially using that site. As a quick little example, we have seen the hamburger menus become ingrained as part of a almost de facto standard across many sites. What this is, the hamburger, you take the bun, the patty, the bun, has become those three little lines, which we call the hamburger menu. Many sites have this. This is the icon that in many ways represents click here to understand what the navigation structure looks like. Is this intuitive? And yeah, I'm bringing up the DeGroote School of Business site again as an example. It's on many sites. The menu, three little lines, small font menu. How easy is that to actually click on as a target? How intuitive is it? And how visible is it? Right? So these are all elements that really do not accommodate for the best support when it comes, in this case, we're talking about older adults. Other principles that we get wrong, user testing. Very, very infrequently do we actually test with older adults. We tend to test with people who are very similar to the designers, which tend to be younger. The only way of really understanding how someone is going to be interacting with that particular technology or with that particular interface is to test it with them. So gaining insights into what are those struggles, what are those successes, and to understand how to shift and adjust that design so that you're not creating artificial barriers. So doing testing in of itself through surveys is great, because that's a first step, because that first step often does not happen. But really thinking about going beyond surveys as well. Surveys themselves have very low granularity. You think about your experience on a particular website. That experience is just summed up within a summative question, a survey as to how happy you were with it, how satisfied you were with it, how easy was it to use. But that journey is very much a journey through that website. There's different highs and lows that you will have. There's different points of frustration. There's different points of confusion. And surveys are not an effective way to be able to capture at the granularity of that journey throughout that experience, through that site. So going beyond surveys. Subjectivity bias. So where the user who's going through user testing, looks to provide responses, sorry by the dog barking, looks to provide responses that they think that the designer, the experimenter, the researcher is looking for. I had a PhD student who was doing a number of usability tests with older adults. Very lovely lady, very easy to talk to, very friendly. The participants, older adults, really enjoyed chatting with her. They all inevitably said that they loved the design and that they thought the design was easy to use and they had wonderful things to say. But we quickly realized that that was because they figured, this lovely lady designed this and I don't want to hurt her feelings, even though I'm very frustrated, I don't know where to look, and it's overwhelming me. All right, so those kinds of biases that definitely do come through within surveys. And the last one, just as a sample, is social desirability bias. You're not so much concerned about what the experimenter, what the designer might be thinking and trying to please them, but you also don't want to showcase that you're confused and that you're lost and that you're frustrated. So you tend to not necessarily indicate so within a survey. Overcoming this, a little plug for the McMaster Digital Transformation Research Center, which is exactly what we do there, is bringing in different kinds of neurophysiological tools that will give you insights, first of all, on the entire journey. What are those frustrated points throughout that journey as you're experiencing that particular interface? And then what is your body telling you? Where are your eyes looking? Are they focusing on the parts of the screen that they should be focusing on, or are they jumping all over the place because they're losing focus and they don't know where to look and they're getting confused? What is our brain telling us? Are we alert? Are we stressed? What is our face telling us? What is our body telling us? Are we stressed? What is our emotions when we're looking at different parts of that interface? So triangulating these neurophysiological kind of tools with the surveys can be a much more effective way to get a true insight as to how well this particular design is resonating and supports different people with different kinds of individual characteristics, such as older adults. So why do we get this wrong? Often, designers tend to design for people like themselves, and they tend to be younger. There's pressure to turn around the next version. So they don't necessarily have the time to be able to really properly test this and vet this across a wider range that is representative of the population at large. And often just the basic underestimation of the size and the potential of their older adult customers. So I've talked about a sampling of how the way we design, the disservice that we do that further exacerbates this digital divide. The next piece to this is around embedded biases. I'm just going to introduce this very, very quickly because I know Jeremy is going into more detail around this. We know that algorithms are pretty much become the backbone to any kind of decisions that we're making nowadays, from anything that might be very, very simple and mundane, like the music that is recommended to us, to something that is much more significant, like who has access to different kinds of services, healthcare and social benefits, as an example. If these algorithms are trained on data sets that are incomplete, they're incomplete because they don't necessarily showcase the population at large. They don't include a proper sampling within the older adult population, then they will naturally reflect biases that work against that particular part of the population. So with that, because I know Jeremy is going to be going into a lot more detail with this, I will hand it over to Jeremy. Thank you.
So my turn for the show of thumbs up, I hope, if people can see the screen, the slides okay? All right, perfect. Thank you very much. Okay, so hello everybody. I'm pleased to be here. So I'm going to be speaking about, as really picking up on a lot of the themes that Milena's really nicely summarized for you and contextualizing them within healthcare and kind of how this plays out in health. And I'm going to go into two areas in kind of greater depth. The first is grounded in my experiences working with our Ontario Health Team, the local health team here in Hamilton, the Greater Hamilton Health Network, and talk about what we've learned or our experiences in trying to bring a health equity, digital equity lens to our work on the Digital Health Secretariat, and talking in kind of concrete terms about kind of two initiatives, how we're trying to pursue it, and what we've learned through that. And then the second part of my talk, I'm going to really go deeper into what Milena was just talking about, is create, the group that I currently lead, does a lot of applied machine learning and applied artificial intelligence in the healthcare space. And there are some real challenges relating to bias that Milena was just discussing. And I'll talk in a little bit more depth about how that plays out specifically in the healthcare space and to what we can essentially do to try to mitigate that. So in addressing digital equity through the work in the Ontario Health Team, we're going to talk about kind of, I should start by just saying that digital equity is kind of a key principle that we adopted on the Digital Health Secretariat of the GHHN. And if you're not familiar with the Ontario Health Teams, the idea of them is that they are trying to bring together acute care, primary care, community mental health, public health, all these different organizations, over 20 organizations in Hamilton that deliver different kinds of healthcare, and sometimes not even just healthcare, also other important social services that are key to driving health outcomes, and try to deliver that care in a more coordinated fashion. And a big part of that is actually putting into place the kinds of digital tools that foster collaboration, but also provide patients to kind of 21st century care, the kinds of services that Milena was describing, whether they're patient-focused applications to promote self-management, virtual care, and other things. So we're really working to put this principle into practice, and there's really two key settings that have been a big focus for us over the last year. The first is in the area of remote monitoring, which has become incredibly important in the era of COVID. And the second is congregate care settings, another area that has been a really major focus since they were major sources of infection during the pandemic. And what we've been learning through this work is that pursuing digital equity in practice requires design not just of the digital tools, but also around the design of models of care and around the infrastructure required to implement these. That we need that kind of design thinking approach that Milena has been describing to extend to the entire way that we deploy these, because it's not always about the tools, it's about how we deploy those tools in practice to deliver care. And I'm also going to talk a little bit, after a couple of years of pursuing this in our work, some of our kind of reflections around the conversations we've been having around the limits of digital equity and how digital equity needs to be embedded within a larger kind of dialogue around pursuing health equity. So one piece of work that we've been working on for the last couple of years is in the area of remote patient monitoring. So what this is about is supporting post-surgical and COVID patients through remote monitoring and virtual care. So this has been done several different ways, but the most patients that have been provided with this service have been patients that are being discharged either after a COVID infection or after a major surgery. And we've been providing them with what we call a connected healthcare kit, which you can see down below there is an illustration of one of the types of kits that we've been using. It includes a tablet where patients can fill out surveys about patient-relevant outcomes, their levels of pain and things like that, as well as sort of objective biophysical measurements, weight, blood pressure, a pulse oximeter that help give a nursing team a sort of view into how things are going for those patients. But as you can imagine, there are real barriers to trying to roll out a service like this. Most patients, as Milena very nicely described at the beginning of her talk, most patients that would get these kinds of surgeries are over 60. And as a result, many of them lack smartphones, internet, or both. Moreover, the technology can be challenging to use. Despite being pretty well designed, it is not always straightforward for all users to make use of this, especially users with language barriers. But what we faced in trying to get this work funded was enormous pressure from Ontario Health, our funders, for a bring your own device model. So we had funders that seemed largely to not be aware of the actual barriers on the ground to providing this kind of service to the residents of Hamilton, as we say, many of whom were over 60 and lacked smartphone or internet. So our answer to this, we were able to successfully push back against our funders. And what we did was we equipped patients with two things, with a kit that included cellular data. So we were able to actually try to get over that challenge around not having smartphones and not having internet. And the other thing we really put a lot of emphasis on was onboarding support. So every patient that was getting registered in this would receive both upon discharge, a visit from our enrollment team that would provide them to an orientation to a kit. And then as soon as they got home, they would get an onboarding call from the virtual care provider, the company that made the kit, to help orient them to how it worked. They would get a kind of live video visit on the tablet that would walk them through. And then at the virtual elbow support from the virtual nursing station that the patients could call at any point if they were having technical problems or challenges. And so we were really trying to not just provide the technology, but also to provide the kind of support that an older population or a population that faced language barriers or lacked technological literacy so that they could actually make use of this. And this was, of course, the downside of this, the challenge from our funders' perspective, is that this was much more expensive than just giving people an app on their phone that they could fill out surveys for. But ultimately, we pushed this because it was fundamentally more equitable. And I am happy to report that with this model, everyone that wanted to participate in this, and there were some people that for various reasons didn't want to, but everyone who wanted to participate was able to participate successfully. And so from our perspective, this was a case where we were able to put those kind of principles of digital equity into practice reasonably successfully. It's, of course, I don't want to suggest we have all the problems solved, but this was an area where we felt like that principle of digital equity, we were actually able to get down at an implementation level to successfully execute on. Now, this work here in congregate settings is something that's happening kind of right now. And it's coming out of the observation. As we looked at our data, we found something that will probably be no surprise to anyone here, which is that as we looked at our data for things like our virtual ED that was introduced during COVID and many other kind of virtual care services, it will be no surprise to anyone that the people accessing those services were generally younger, better off, etc. Right? People that had all the advantages, and our most vulnerable residents were generally not accessing those services. If they were accessing them at all, they were certainly accessing them at a much lower rate than our better off patients. So there was a real goal we had around better facilitating virtual care. And we particularly focused on congregate settings because this is a setting too where we were seeing really virtually no uptake of virtual services. And that's particularly important in pursuing digital equity because often our most vulnerable patients live in or are residing in congregate care settings, which can range from anything from a long-term care facility to a shelter for the underhoused. So there are a ton. As we started to dig into what would be involved in getting better virtual care in our congregate settings, we encountered barrier after barrier. The first off is simply that most of our congregate settings have little or no internet access. Very few smartphones in those settings, very few residents have their own smart devices. There's also limited private spaces, which is really important in a healthcare context. Simply because somebody is poor does not mean they don't deserve the same privacy protections that everyone else did. And that can be a real challenge in these congregate settings where by definition, people are housed together. Also, when you look at some of what would be the easier solutions, tablets, simply providing tablets, there's a tendency for those to wander off. And let's just say that there were some tablets provided that we've never seen again in a couple pilot projects. So we can say with some confidence that can be a real challenge in these environments. And even sort of more fundamental, especially when you're dealing with the most vulnerable, whether those are people who are refugees or underhoused or others, they often lack the necessary identification that you would require for authentication to virtual services, whether that's access to patient portals, virtual care, or otherwise. So there are a lot of challenges if you're going to try to provide these services in a congregate setting. So we really began an initiative really in the last few months to try to, in a systematic way, address these gaps. And we began, as would happen when you are folks from healthcare settings, we really started with a major focus on healthcare. But as we started to engage with shelter health, as we started to engage with the shelters themselves and others, we very quickly heard from them that their priority, they were happy to have these services potentially expanded to include healthcare, but they were much more focused on things around the social determinants of health, such as Ontario Works and housing supports and things like that. So where we're currently working around is an initiative to bring in, we use this word kiosks quite loosely, but the idea of secured computing devices that won't just wander off, that can be put into private spaces, likely equipped with either cellular internet or bringing internet into the shelters in order to provide digital access to these services. And this is, as I say, it's work that's ongoing right now. But one of the important things, and we really picked up on the kind of principles that Milena and others have been describing around the importance of co-design for your community. So we've engaged the shelters, we've engaged shelter health, and are hoping to engage some shelter residents to help us co-design these. So it's going to take a little while before these are really actually in the shelters, but I feel like we're on the right path by engaging those folks in helping us design it so that what we actually result in addresses the needs of the populations that we're trying to serve. And we're beginning with the homeless shelters because, of course, they are housing the most vulnerable of the most vulnerable. Our hope is that if we can succeed there, then we can start to look at some additional congregate care settings. And there are existing programs to help with those settings like LTC Cares and others, but actually sometimes, as I've sort of discussed, sometimes getting that infrastructure piece so that people can access those services is something that we need to settle first. So in all this work we've been doing, and again, there's a lot more work to be done in the digital equity space in Hamilton and elsewhere, but we have started to bump up against even just the limits of the digital equity lens. And our sense is that while digital equity is really important to pursue in the healthcare context, it's really not a panacea. Because the reality is that many people face structural inequalities that go way beyond their access to internet, smartphones, or accessible design. And what we see is a lot of digital health, not all of it, but a lot of digital health is really focused on things like self-management and behavior change. But for people who are underhoused, poor, and face food insecurity, digital tools focusing on behavior change, like healthy eating, will not make a significant impact on their health status because there's too much social deprivation there. And so it's not that to say that digital equity isn't important, but that we increasingly are thinking about digital equity within a broader equity framework that's focused on addressing the social determinants of health and well-being, of which things like internet access and things are a key. Increasingly, I think more and more people are thinking about that as a social determinant of health. And so we're just trying to not kind of lose the forest for the trees around digital equity. And it's true that in our opinion, there's some folks who will benefit more from in-person care than virtual. And so sometimes we're really trying to say, let's get people the right care. If that's virtual care, great. But if it's in-person care, that ultimately what really matters is that they're getting the care that they need and is best suited to their needs. Okay, so that's it for thinking about kind of digital equity in practice. I want to next switch to kind of my day job here, which is as somebody that leads a team of AI developers in the healthcare space, and talk about some of the challenges that we and other people have been encountering around kind of AI and fairness. And so the first thing I'm going to talk a little bit about in greater detail is around how AI can actually learn to be racist, or ageist, or sexist, or ableist, or anything else. And talk in more granular terms about what types of biases are specifically encoded into healthcare data, and wrap up with some at least brief thoughts around how AI developers can try to mitigate these concerns, although I think this is very much an open problem and not one that has been solved. But at least I'll try to provide you some guideposts around how we think about it and approach these problems. So I think at this point, it is pretty well established in the literature that AI can, in fact, automate racism or any other form of discrimination. And if you'd like to dive deeper into how this can really happen, there's an excellent paper in the journal Science around dissecting racial bias in an algorithm used to manage the health of populations. And I'll discuss it at a high level, but I think this paper by Obermeyer is well worth anyone's time if you're interested in going deeper. But where one of the sources of this sort of automating of racism can happen is that many variables in healthcare databases are socially mediated in one way or another. And so what I mean by socially mediated, many healthcare variables, of course, are just objective measures. Your blood pressure is your blood pressure. You can take your blood pressure and you can be reasonably confident that it's objective. But there's a lot of other things in healthcare that can either include some type of subjectivity. So if you think about how a clinician will document a clinical encounter, there's been tons of research to show that how that clinician documents the encounter will reflect their own perceptions of the world and can include their own biases or prejudices in one way or another. And that can get kind of written down in the clinical notes, which then can go on and infect a person's whole course of care and how they're perceived by other healthcare professionals. But even things like, that might be, quote unquote, more objective can be socially mediated. So if you think about something like medication adherence, so whether or not a patient is adherent to their medication, did they take their medication or not? Well, that might seem like a very objective measure, but we might ask, well, why did a certain patient take their medication versus another patient that did not? The patient that did not might not be a bad patient. They may be facing any number of social or income-related barriers that made it difficult for them to, say, fulfill their prescription and take their medication. So you need to be very careful around the kinds of variables that are used in an AI model, because they may reflect larger patterns of social inequality that can then be essentially encoded into an algorithm to replicate existing patterns of discrimination. So let me talk in a little bit more depth here about where this happens in a really dramatic fashion. So one thing that's interesting about our population health data, for those that are not aware, is that there's a lot of data missing from our population health data. So you may know that Canadian health data can be very fragmented. One thing that we have that's very high quality is we have administrative data from hospitals around outpatient visits to hospitals, ED visits, and inpatient visits. What we don't have nearly as effectively is, say, in granular information about what's happening in primary care, or what's happening in specialist offices, or what's happening in mental health services. And even when we have that data, it's rarely all brought together. So what's often used as a proxy for health need is health expenditures. And from a statistical point of view, this can actually make a lot of sense to you make a lot of use of these kind of health expenditures, because the strongest predictor of a person's future healthcare costs is actually their previous healthcare costs. Like if you want to produce who are going to be our high cost users next year, one of the variables that can get you very high performance is somebody's expenses this year. But the challenge is a lot of AI models used to identify patients for preventative healthcare programs often use healthcare expenditures as a variable. But healthcare costs are precisely one of these things I've been talking about that are socially mediated by barriers to accessing healthcare. So there's a ton of people that can't necessarily access healthcare the same way that others can. Sometimes that's driven by race, sometimes it's driven by language. Lots of people who come to the country undocumented will not be able to access healthcare. And so if you use health expenditures for a particular population as a predictor of health needs, you can unintentionally introduce all of those barriers into your model. And so what happens is in practice, and this is what the Obermeyer paper really dissects and how it happened within a particular population health algorithm, is that AI models will tend to offer fewer preventative services to marginalized people who are equally in need. That is, they have the same disease burden, but historically, one population has not been able to access equal care. And so the result can be essentially an unequal recommendation. Another key bias that can be introduced is that there is a lot of data missing within healthcare data sets. So I'll give you a few examples, one of which many will likely know, that women are recruited into clinical trials at a much lower rate than men. And my group in particular does a lot of AI research on clinical trial data, because clinical trials, one of the benefits of them is that the data sets are incredibly high quality, because there's often on-site monitoring, there's very low rates of missingness. They're ideal data sets from a certain perspective to train AI models. The challenge is that if they may include a lot of missing data, i.e. for women, and so you're much less likely to get equal performance in a predictive model if, say, only 20% of the participants that model was trained on were women. Another important consideration if you're using observational data sets is that most Canadian jurisdictions don't systematically collect data on race or ethnicity. And this can be challenges for many reasons. And one of the biggest ones is that if you don't have that data, it's hard to tell if your algorithm has accidentally learned something related to race or ethnicity, because you're going to have a very hard time actually interrogating your algorithm to determine whether that pattern is in fact there. And you might wonder, if there's no race or ethnicity data, how could an algorithm learn to be racist if it's not able to use that data? Well, there's a bunch of ways that it can happen, but if you think if nothing else, there's a lot of things that are correlated with race or ethnicity. Often one of the major ones is postal code. Right? When folks immigrate to Canada, they'll often initially congregate in certain neighborhoods where they become kind of ethnic enclaves, where there's a lot of folks of a particular ethnicity. And if that in itself, that postal code can wind up becoming very important in a predictive model. And your algorithm may, as a result, unintentionally learn patterns that are driven in some way by race or ethnicity, and then you won't be able to dissect it. Ethnic diversity is also not evenly distributed across Canada, meaning in many communities, and thus in many community data sets, may be predominantly white. So this can be a huge challenge. One data set I had the privilege of working with recently, as we looked at it, we realized that it was 95% white, driven not at all by any sort of malfeasance on the part of the people that collected the data, but they were collecting data at a clinic in a predominantly white area. And so if one were to kind of uncritically use an algorithm developed on that patient population, it would almost certainly produce either inaccurate or unfair results when applied to a general population. It's also important to be aware that data for Indigenous populations may either be restricted by OCAP principles, or if you're accessing it through administrative data sets, may well be incomplete because many Indigenous people will access some of their healthcare through provincial assets, through provincial services, and others through federal services. And those databases are very rarely brought together. And so a lot of that data can be incomplete and thus, again, may systematically disadvantage Indigenous peoples. All this means that whatever existing data sets being used to train an AI in the context of healthcare, there's very likely a degree of bias built into it. So what can you do about this? So first and foremost, it's just really important to be continually aware of these issues and to take them seriously. And that might sound sort of almost obvious, but in my experience, there's a lot of technological optimism in places like Silicon Valley and really just sort of around AI in general. And there's a sense in which I see frequently people not taking these issues particularly seriously. So I think it's just first and foremost important to be aware and to really take them seriously. I think it's also really critical to avoid the use of proxy outcomes as labels whenever possible. It's not always possible. We don't always have the kind of data that we want to in healthcare data sets, but whenever possible, it is best to avoid them. If you're in a position though where you have to use a proxy outcome, then it's really important to objectively assess the degree to which that proxy outcome is socially mitigated, right? And what types, in which types of ways can that be, is it socially mitigated, and is it possible to control for that statistically? And then finally, it's really important to try to use representative data sets wherever possible. I know that in my experience, it's much easier to access data from your own health system than it is to try and get access to data at ICES or to sign painful data sharing agreements with other hospitals. But it is essential to always pursue external validation of AI models. It's really alarming, actually, in the AI literature in health right now, how often people are kind of doing a local study, getting kind of a cool result, and then kind of declaring victory and not doing the next step, which is to take that model developed on a small community in a place like Hamilton or a place like Vancouver or wherever, and take that model and then test it on data from other jurisdictions that have different makeups and different populations. That's just really critical in order to be developing AI in a responsible fashion. So again, I don't claim to have all the answers in how we best mitigate bias, but these are kind of guideposts that my team use to help us navigate this space and to try to make our development of AI products as responsible as possible. And that's it for my talk. So I'll turn it over for, I think, discussion.
Thank you so much, Jeremy and Milena. Those were excellent talks, and I think they are topics that come up among the MIRA community repeatedly, and we had a few questions bubbling up even in the chat as you were talking. So thank you for your perspectives. And I think I'll start with a question that came from Brian Detlor, who's in the DeGroote School of Business. So he said that during this talk, older adults are categorized as those over 60 years of age. However, there are differences within this population. There are younger, older adults, 60 to 75, and much older adults, for example, over 85, and these populations are not homogeneous. Some older adults are technology competent and well-equipped to pay for training if needed. Others who may be on the younger end may be less equipped to participate in digital training. Should we, as an academic community, rethink who older adults are and how we should approach studies involving this population? It's a difficult problem. Is age really the factor, or is digital literacy competency a more important factor to consider? And I think Sharon Livingston is agreeing that this is an important point. And I think this also speaks to sort of intersectionality and some of the things that Jeremy was discussing toward the end of his presentation. So I don't know if either of you want to address that or both.
I'm happy to jump in first and give Jeremy a little bit of a breather. So absolutely agree, Brian. I think in many ways, you know, we naturally tend to categorize people because conceptually it's easy for us to do so, right? But when I was talking about individual differences, like I really place emphasis on the individual, because exactly as you said, one 60-year-old might be very, very different in terms of their capabilities, their perceptions, and everything else compared to another 60-year-old. Same thing, somebody who's 30 versus another 30-year-old, or somebody who's 70 versus another 70-year-old. So I very much focus in on the individual. And then how do we look to breaking outside of those artificial chronological age buckets, and think about how do we design and how do we evaluate for those that might have different types of capabilities or barriers, whether it's a perception, it's a cognition, action, attitude, socioeconomic, geographic, all of the things that we heard about today. How do we design so that we're not creating artificial barriers for people that have divides? And I think sometimes we fall into that ease of categorization by buckets based off of a number. But I think it does come down to that individual, what are those individual barriers, and how can we make sure that we're not artificially creating barriers for those that have those divides?
I totally agree, Milena. The only thing I would add is that we found that in our arguments with Ontario Health, it was useful, though, the statistic around that, people age 60 and older, have essentially lower access to smartphones and lower access to internet, because Ontario Health didn't want to appear ageist. And so it can be a useful heuristic politically, but I agree from a design standpoint completely, we need to be thinking more along the lines of individuals and less categories.
Thanks. And Parminder, do you have something to add?
Yeah, I was just going to, I'm not sure it's a particular question or a comment. Milena, when you talked about this issue of age and digital literacy, you emphasized something about thinking about individuals, right? And that works quite well from a clinical care point of view, if we want to go. But when we talk about public policy, we make public policy at the population level. How do you sort of bring this individual perspective to population perspective? Because we know from every aspect of life that there will be people at somewhere around that distribution that we have who will not follow that the individual tailored approach. And that's why I was kind of intrigued by Brian's comment about thinking about digital literacy embedded within the age, because that can easily translate itself into a population health approach that sort of shifts the whole curve rather than the tail end of the distribution if we focus on individuals. Any comment on that?
Yeah, more so again, to echo from Jeremy's perspective, is that from a public policy perspective, categorization, I'm using air quotes here, is easier, right? But and shifting our perspectives around how we support different aspects of the population away from something that might be more tangible as a number is challenging. But it's understanding that not every individual is the same within any particular segment. People react differently, people have different experiences, people have different expectations, which will greatly vary in how well they're able to consume information and be able to effectively communicate with the technology. But if we are using as a proxy age as a way to think about how do we better support people who might not have as much access or have barriers to access to certain kinds of technologies or certain kinds of internet or the services that come with it, it's a step, right? It's a step that will hopefully also be able to capture those that don't necessarily nicely fit into those buckets.
My point was that I don't think we are going to reach each and every individual. If you start to think about concepts that sort of shift the whole distribution, there will be some people who will be left, and they always do for whatever reason. How we conceptualize and shift that whole distribution is probably a much more effective strategy than borrowing from the precision medicine approach that each and every individual will have a very tailored care, which itself has its own barriers. I think the marrying the two might be an interesting approach to think. Anyways, I really enjoyed both of your presentations. It was great.
That was an
Thank you.
important comment. Thank you. Yeah, I think one way to maybe think about it is to think about barriers, right? And of which digital literacy is one, physical ability to interact with the technology, whether that's visual impairment or motor impairment, thinking about different types, and then each individual may have their own mix of barriers that they're facing, right? They might be socioeconomic around their ability to access, but sort of systematically thinking about all the barriers that people can face might be, and then recognizing that individuals will each have their own constellation of barriers, that might be a way to marry them in a way that is useful for public policy, because public policy can in fact address things like, you know, your ability to interact with technology if you have visual impairment, or your ability to access internet if you live in a rural area, etc. So maybe a thought.
Oh, we're near the end, but we do have one more question, so I will ask it. And so this question is just in the chat box, you can see yourself, but when employing AI, mostly it takes time to collect and train a model, and then an event like the pandemic might change the entire system in different aspects. What approach can we take to close the gap between the time of data collection and implementation phase?
Good question. So, in fact, it was there were lots of people trying to do AI at the beginning of the pandemic with really bad data sets. And I think that a lot of those probably did more harm than good, if nothing else, to the reputation of medical AI. So it is a very real problem. And even if you're using observational data sets, one of the challenges we're finding is, like, everyone here, I'm sure, that has done any work with ICES will know that data is 18 months old. And so it is, the timeliness of data is a really big challenge. There are efforts afoot to kind of improve the timeliness, but there is actually a profound need to modernize the Ontario, really everywhere, but especially the Ontario data infrastructure, because it is just not set up for like nightly extract. Data warehousing, like the idea of nightly extracts, has been around for 20 years, and yet we are still stuck with kind of once a year kind of batch extractions for Ontario data, and it's ridiculous. So there is a real need. There are some efforts afoot to modernize the data repositories, the CDRs, for various purposes. It's going to take a few years, but I think that fundamentally is one of the most important things to change, is just Ontario's health data infrastructure.
Thanks very much for that answer. Parminder, do you have another question?
Well, question in the sense, both for Milena and Jeremy and others on the Zoom, as this talk was organized by McMaster Institute for Research and Aging, and if as an institute we want to support research in this area, especially focusing on older adults, what are the areas that, Jeremy, yourself or Milena, from your point of view, and others on the Zoom, that we should pursue, that sort of moves the needle? Some of the examples I saw from Jeremy's presentation could easily be adapted to what we do, and some of the things from Milena's presentation as well. I'm just thinking, we would like to develop something in this space, and how should we do it? And what are the areas that you think can give us some food for thought to have future conversations? It's just an open question. There might not be an answer right now. It might require another set of meetings to discuss that further. That's fine. I was just looking for some early thoughts around that.
Well, I mean, I think that resources like the Canadian Longitudinal Study of Aging are going to be really important, right? Whether they're to help us train better algorithms that can actually that better understand the aging population, but also potentially providing a group of people that might be willing to sort of expand and participate in whether it's the design of digital health interventions or otherwise, would be really critical, because it's the missing. I can't emphasize how much data we don't have about the aging population, and we're not going to get anywhere from the AI side without that data and without people interested and willing to sort of participate in the creation of that research. So that's one piece.
And I would just further add, coming back to how do we help to narrow that divide, and more so focusing, because I am a behavioral researcher, is focusing in on what are the cognitive and emotional support systems that we should be thinking about, and how do we help to overcome some of those attitudinal barriers, some of those digital skill barriers, some of those fear barriers, and how do we better encourage truly inclusive design and evaluation of the types of tools and the interfaces that we develop, and providing the resources to be able to help to do so, because it's not necessarily easy. And I'll put in just a last little plug for the McMaster Digital Research, McMaster Digital Transformation Research Center, where we are looking to bring in, through a CFI supported grant, a mobile usability lab that will take these neurophysiological tools for effective, more holistic assessment and a design thinking approach to where older adults are. So not having the expectation that they're going to be coming to your lab at McMaster University, and how are they going to get there? Are they going to feel safe coming there? But being able to go to them, to be able to help support them and involve them in these important design and evaluation exercises, so that we don't create or don't continue to exacerbate these barriers just through not having the appropriate design elements in place.
I think, Audrey, that we should bring some of the individuals who are here to discuss and see how we can develop a program of research in this space that MIRA could seed fund to get it off the ground, and see, because Brian is doing work in digital literacy. Brenda put together a proposal around training in digital health in older population. Milena, your work, Jeremy, your work, Norm Archer is looking at these things, Cynthia Locker. So we do have groups of people who are looking at some of these things, and I think it'll be a great opportunity for us to provide leadership in this space. And as some of you might know, we can, if the right group of people come together and develop interesting ideas, we can kickstart with up to $1 million in grant over 3 to 4 years. And I'm sure if we develop, as our experience has been, that we can attract additional dollars from other sources, from competitive sources, to really build a strong program of research in this space. And I think it's badly needed. And pandemic has really shined a light on this whole inequity. And I really like the perspective that both Milena and Jeremy provided in relation to behavioral aspects are important, and so are social determinants of health. If somebody doesn't have money to buy food, they are not going to go into interventions that is the same thing. Some of the work that is happening in Toronto area, prescriptions are written, but the person doesn't have money to go and buy prescriptions and doesn't have a health insurance coverage. They're not going to take those medications. And I think we really need to think about some of these areas. And Audrey, it'll be great for us to organize another meeting of this nature where we can actually start exploring, see if we can develop a program of research in this space. And there's a lot happening, MAC-M3, that Marla and then the Emboldened project that are also targeting vulnerable populations or looking at early technologies that support older people. So there's already happening. So we might have a critical mass of doing something really interesting here. Thank you. I really enjoyed the talk.
Thank you to everyone for staying on for a little bit longer, but I think we had some really good questions and conversation, and it looks like it's going to continue. So keep your eyes on your email, and we'll try and bring people together to keep this conversation going. Thanks again to Milena and Jeremy for great talks today, and to everybody for their questions and comments.
Pleasure. Thanks so much for having us.
Thank you so much. Thank you. Have a great day, everyone. Thank you.